Good evening, everyone. I first of all want to thank the IFPMA organizers for giving me an opportunity to be here, which otherwise I wouldn't have actually. So anyway, so this is a section on young innovators on Spotlight. I want to tell you a little bit why my interest got into science and research and innovation. So when I was growing up in India, you know, they always tell you, oh, you should become a doctor or an engineer when you grow up. So I said, okay, I want to become a medical doctor. And I studied for the exams, and I didn't do very well. So I didn't pass, basically. So then I thought, okay, let's do something which is quite similar. It's a pharmacy field. It's professional. It's a four-year degree course. So I thought, okay, let me do that. So I did an undergraduation in pharmacy from Delhi. And when I was doing this undergraduation, I realized that I don't want to become a pharmacist, but I'm more interested into research kind of thing. So then I decided to go ahead and do a master's in pharmacy from a very good college in India. And I worked on making more biocompatible surfaces for implantable medical devices like stents. So I further, a lot of people at that time were going to the United States to gain experience abroad in research and science. So I also applied, and I was quite fortunate to get into University of Connecticut in a very good lab. And I did my PhD there in gene delivery. It's very different from what I did from my master's. So then I thought of doing some more research in another area which is totally different from my master's and PhD research. So recently, like currently I'm working on a novel nasal delivery system for treatment of seizure emergencies. And I will talk to you about this project in a little bit. So a lot of people are aware of epilepsy, epileptic attacks. I'm sure, like I was talking to some people in the morning, and someone or the other in their family or relatives have had epilepsy, or they still have epilepsy. So these epileptic patients usually get very severe attacks. And if these attacks last very long, like longer than 5 minutes or more, it's an emergency condition. They need to get treated. They need attention. It's called seizure emergencies. Now, these conditions are often accompanied by convulsions, and a lot of times patients are unconscious. As you can see here, that patients are actually lying on the floor. Somebody is there to attend them. The best way, or the way so far, is that the person who is taking care of this epileptic patient who is lying on the floor, they'll call 911. They'll call the hospital facilities who will come, take the patient, take him into the hospital, get the IV access, get the drug going into his body, and he feels better. Now you can imagine that if you wait for the hospital staff to come and give you assistance, it's already late, right? The damage is already done. You would need something within like 10 minutes at the most to get the treatment, like get the drug right with you and in your body within like 10 minutes. So another thing that people have tried is giving the drug by the rectal route. Now, a lot of people would agree with me that rectal route is not very convenient. Sometimes it's embarrassing. It's not very acceptable. So we have come up with a delivery system or with a treatment for these epileptic patients where they can take the drug by nose. Of course, these guys lying on the floor cannot take it themselves. So the person next to them can help them, or a family member can help them, giving that medicine through the nose. So that nasal delivery thing is actually a prodrug-enzyme based system, and I'll talk to you about that in a couple of minutes. The major challenge when you want to give something through the nose is that nose has a very limited volume, like very small volume of any liquid can get into, like 100 to 200 microliters. And the drugs which are used for the treatment of epilepsy, which I forgot to mention, are benzodiazepines like diazepam or midazolam. So when you want to give these drugs for treatment of epilepsy, they are very poorly water soluble, like they don't like water. They're not very good solubility in water. So the challenge is, how do you get all the drug, the amount of drug which is required to treat the disease, how do you get all that drug into water or the aqueous system? That's the main challenge. Now, since these drugs have a poor aqueous water solubility, the maximum concentration that they can have in water is really low. It's in microgram per ml, and that's not good enough to treat the patient. So you need something that the drug is in solution in milligrams per ml, like it's really high concentration. So this you cannot do by making saturated drug solutions, but you can certainly do by having supersaturated drug solutions. So for us, let us understand about supersaturation. So let's say you have a beaker which has sugar saturated in a hot water. Um, when you let the solution to cool down, sugar is now in a supersaturated state. Supersaturation basically means that you are having that drug or sugar in this case in an amount which is more than the water can hold. So it's a supersaturated state. If you wait long enough, the sugar will start to crystallize out from this supersaturated state. This is because supersaturation provides only a temporary stability or temporal stability to the sugar or the drug. But what you can really get is that you can achieve a very high concentration of sugar in water if you heat the water like this in supersaturated state. So current drugs for intranasal benzodiazepines, excuse me, they are either made with low pH. I don't know why this is running forward. But they are either made using a low pH condition, which can solubilize the drug more, or using organic solvents. But these conditions, they cause irritation to the nose of the patient and reduce the patient tolerance. So we came up with our prodrug-enzyme systems, which are aqueous, physiological pH-based formulation, and they can provide a very high dose of the drug by means of supersaturation. Now, when we talk about our prodrug-enzyme system, it will work like this. So let's say we have a device. We have prodrug in one compartment, enzyme into another. These two are in the dry form. And in the center, we have an aqueous buffer. So once you actuate this device, the enzyme will combine with the prodrug, activate the prodrug, form the parent drug in supersaturated concentrations. And if you do this mixing just before putting it to the nose of the patient, the drug in the supersaturated concentrations will be rapidly absorbed into the brain, either directly via olfactory neuroepithelium or indirectly via systemic circulation. So I think I didn't focus this previously, but for epilepsy, you want the drug to enter the brain to start working and cause seizure cessation. That's why we are focusing on delivery to the brain. So if we give it by nose, there are chances that the drug will be formed at a very high concentration if you use this prodrug-enzyme system, and it will be absorbed to the brain very fast, like within 5 or 10 minutes, nose-to-brain delivery. Now, a key feature of this prodrug-enzyme system is that we are mixing the prodrug and enzyme at the point of administration, like just before putting it to the nose. So when we think about supersaturation, there are chances that the drug can precipitate out, right, as in the previous sugar slide I showed. So you really want that the drug should be absorbed much faster than, like earlier than the drug starts to crystallize out. So we try to delay the process of crystallization by producing supersaturation at the point of administration, like just before putting it to the nose. So that's one advantage of our system, besides producing drug at a high concentration. So after understanding about the prodrug-enzyme system, our task was to develop this prodrug-enzyme system for diazepam, which is first choice drug for seizure emergencies. It's used as IV or rectal currently, but we are coming up with this nasal system, which will be more convenient and faster for the patient. So when we talked about diazepam, we thought, okay, what prodrug we should use? So we looked up to the literature, and we found this prodrug called avizafone. It is used in French battlefield as an antidote for organophosphorus poisoning. So we decided to use this as a prodrug. It's a dipeptide of diazepam, and it hydrolyzes to diazepam like this. Now our task was to identify the activating enzyme, that is the enzyme which will convert the prodrug into the drug. We did a series of enzyme screening studies, and we identified one enzyme. It's a protease from Aspergillus oryza, which is a rice fungus. We identified this enzyme, and then we did a lot of permeability or absorption studies with the prodrug enzyme systems, and we compared that to saturated drug solution. So in our studies, we found that our prodrug enzyme system showed 16-fold faster absorption compared to the saturated drug solution. That means it can get the drug delivered to the brain much faster than if the drug was alone in water, which will not be a very high amount, the clinical dose. And because it's nasal, so the patient can get it faster, more effectively, and get treated more quickly. So concluding this section, that we developed this prodrug-enzyme system for fast absorption of diazepam for the treatment of seizure emergencies. However, if you consider this, this system is not only useful for epilepsy. It can be used for any other treatment, any other medical emergency condition where you need fast absorption. For example, even in case of migraine, or in case of tumor, if you have local tumor, you can just inject this prodrug-enzyme into that, and it can produce drug at a very high concentration that will get rapidly absorbed and kind of give a burst release of the drug, and you can treat it more effectively. So our system is not only applicable for epilepsy, but it can be used for other medical emergency conditions as well. So with this, I want to thank you all for your attention, and I'll be happy to answer questions. Thank you.
So if you have any questions, please, we've just got about 2 minutes. You could ask Mamta if you have any particulars relating to this.
All morning long, we've been wondering whether there is a role for the industry in changing health delivery systems, changing the real cost of healthcare, which is the interventional profession. You just give us an example, and I'm wondering if there aren't a range of ways in which systems can be designed that deliver this for previously diagnosed patient, identifies maybe the proper dose, like closure, insulin pump, or this kind of delivery system, which is now made possible, that would take the professional, the ambulance driver, out of the picture and take all those costs out as well, so that the patient takes control of the disease.
Yeah. So your question is any other system, or?
Have you looked beyond the couple that you've identified and think about the use of this as a personnel saving system as opposed to a time saving system?
I see. Yeah, that's an interesting question, but no, I think we've been pretty much working on this system, this disease, but nasal delivery is quite common. Like, it is being used for other ailments as well, and I cannot comment on industry point of view. I'm sorry, but yeah, it is definitely more convenient, and there are lots of products in the market with inhalation, with intranasal system. It's more convenient, faster. And if you have something like this, which is, this product is already available. It's not new. I mean, if you think about it, an enzyme is commercially available. So synthesis cost goes down for the industry. If you think about something like this, which can reduce the cost of initial, components, what you would need for the system, I think that would be a contribution from my side. So,
Please, just last brief question.
Just a comment. So hypothetically, these systems actually can remove cold chains or something. You mentioned that you have. You mentioned that you have two drug and dry state. So yes, so both of them in dry state. So hypothetically, this system, I don't know about this, but for something else, it can be alternative to remove cold chain, because in this case, if something in dry state can be stored in room temperature.
Yeah, actually, that's the reason that we don't want to put one of the system in water, because then another study, stability studies of whatever component we should decide to put in aqueous system. So I think, yeah, that's a good point. That, in fact, there are companies who made some devices like blister packages where you can have drug in the dry state, and if you just push it in, like how you open the capsule in the blister pack, it will get into the solution, the water, whatever aqueous phase, and then you can use it. So you don't have to worry about stability issues and save costs there also. Thank you.
Mamta, thank you very much.
Thank you.